talking about gonioscopy, identification of open and closed angle pathologies. Now, gonioscopy is a very important but underrated investigation when it comes to glaucoma. It's very important to identify angle closure disease, especially in our country, because in Western countries, the data shows that 80% of the glaucoma that they have is actually open angle glaucoma, and gonioscopy is not really performed in all the glaucoma patients when in Western countries, but in our countries, almost 50% of the primary adult glaucomas that present to us have closed angle. So coming to when you are doing the gonioscopy, the first step is to identify what is the posterior most structure that is visible when the patient is sitting at the slit lamp and you have applied the gonioscope and the patient is looking direct in the primary gaze, not looking up or down. So in the primary gaze, you have to identify what is the posterior most structure which is visible. Now here we can see when you make a very thin slit and project it only in the angle, you will be able to see that there is a corneal wedge formation which forms when the clear cornea fits into the opaque sclera in a U-shaped manner, and this marks the origin of the Schwalbe's line. This is where your Schwalbe's line lies. So once you have identified the corneal wedge, you will be able to identify the structures which are lying behind the Schwalbe's line, which look like this. So if this is the place where your Schwalbe's line is, this is the place where your corneal wedge will form, and behind the Schwalbe's line is your trabecular meshwork. Trabecular meshwork may be anteriorly non-pigmented and a posteriorly pigmented trabecular meshwork, following which there is a white line which is the scleral spur, followed by your grayish structure which is the ciliary body band over which your iris is inserted. Now when you identify and differentiate between open and closed angle, you will see two most important things. In open angle, all the angle structures are visible when the patient is looking in the primary gaze, while in closed angle, none of the angle structures are visible. Not just that, if you carefully look at the beam of light that is falling over the iris, it is flat in open angles, while when you look at angle closure, it is a convex beam that is falling over the iris, notifying that closed angle have an anterior bowing of the iris that is present. Now, second most important thing is when the patient is looking in the primary gaze, you note down what is the angle recess, that is the angle formed between the two beams and the iris configuration. When you look at the angle recess is the angle that is forming between the two beams over the cornea and the iris. The iris configuration in the normal angle looks like this, which is a flat iris configuration. The beam that is falling over the iris is flat, while the convex iris configuration is usually present in angle closure disease, where the beam over the iris is convex and you cannot see any angle structure beyond your corneal wedge formation. While in concave iris configuration, you are able to see that your iris is bowing backwards, and also additionally in this case you can see that there is a very densely pigmented trabecular meshwork that is present, notifying that posterior bowing of iris is in this case leading to pigment dispersion, which is leading to pigment dispersion syndrome, and additionally might cause glaucoma in the long run. Now, after you have noted the things that are to be seen in the primary gaze, then you do either indentation or manipulation gonioscopy. Manipulation gonioscopy is performed using gonioscopes which have a larger well, where coupling fluid is used, the Goldman type gonioscopes, and where the well of the gonioscope, the edge of the gonioscope rests over the limbus. If you inadvertently press these gonioscopes a lot, they will lead to artificial closure of the angle. So the gonioscope should be kept over the cornea gently, not to close the angle while pressing too much. So while you're doing the manipulation gonioscopy, you ask the patient to look towards the mirror that you're seeing in or opposite to the angle that you're viewing. While you ask the patient to look opposite to the angle you're viewing, you can see that in this case there is no angle structure that is visible, but when the patient looks towards the mirror, the angle structures and even the ciliary body band, it becomes visible, and there is no other abnormality that is seen in the angle. This is a primary angle closure suspect case where at least 180 degree of the angle is occludable or not visible in the primary gaze. Also, you can sometimes, when you broaden the beam of light, broadening of the beam of light itself can cause opening of the angle. Additionally, when you do manipulation gonioscopy in patients where the angle structures are not visible in primary gaze, you might be able to see some other abnormalities. For example, you might be able to see some blotchy pigments in the angle. You might be able to see that the iris is partly stuck at the trabecular meshwork. You might be able to see some goniosynechiae like in this case, or some small goniosynechiae and blotchy pigmentations. This can be present in primary angle closure or primary angle closure disease, which warrants that a YAG PI must be done in these cases. Now, indentation gonioscopy is done using the small well gonioscopes, where the Zeiss type gonioscopes, where the gonioscope rests over the cornea. Once you press the gonioscope onto the cornea, you will be able to see some corneal folds, as you can see here, and the angle which was the trabecular meshwork which was not visible here becomes visible and the angle opens up. This helps you differentiate between appositional versus permanent synechial closure that can be present. In permanent synechial closure, on manipulation as well as indentation, no angle opening is seen. Level of iris insertion. Now, sometimes you will be able to see that the iris configuration is flat, the anterior chamber is deep, but still the iris is actually originating over the trabecular meshwork. So, the level of iris insertion could be at the level of the ciliary body, at the level of the scleral spur, or just behind the trabecular meshwork, over the trabecular meshwork, sometimes just at the anterior trabecular meshwork, or even just at the Schwalbe's line. These abnormalities are usually present in juvenile open angle glaucomas, or they might be present in congenital glaucoma. Sometimes you also will be able to see other abnormalities like pigmentation. The grading of the pigmentation is done as such that grade 3 pigment is called equal to the color of the cornea. Grade 4 pigment is called something that is darker than the equal to that of the iris. Grade 4 pigmentation is something that is darker than that of the iris, usually found in pigmentary glaucomas, for example, pigment dispersion syndrome or pseudo exfoliation or even ocular melanosis. And grade 0 pigmentation is where there is no pigmentation. Sometimes you might see that there is flat iris configuration and you are not able to see any angle structures. So in these cases, you have to make a corneal wedge and see the iris configuration and identify where actually the angle structures are lying. Early on when you're doing gonioscopy, it's easy to confuse between a non-pigmented angle versus a closed angle. So now coming to goniosynechiae. Goniosynechiae can be present in various diseases. For example, broad-based goniosynechiae, they can be present in uveitic glaucoma. In Axenfeld-Rieger syndrome, where you have a posterior embryotoxon, filiform synechiae might be attached to the band-like Schwalbe's line that is present. Abnormal vasculature. This is very important, especially when it comes to the multi-speciality practices where especially the retina practice is also present. The normal angle vessels are usually seen in light-colored irises. Also, the normal vessels, they have large loops near the root of the iris. They do not cross the scleral spur. They are radial vessels which follow the normal iris structure. While looking at the new vascularization of the iris, the new vascularization are tufts of vessel that grow from the iris root. They cross the scleral spur and they arborize over the trabecular meshwork. This is extensive neovascularization that was seen in a person who had ischemic CRVO. Sometimes while you're pressing the gonioscopy or you've put the gonioscope for a longer time over an eye, you will be able to see some reddish hue that might come in the Schlemm's behind the trabecular meshwork. This is blood in Schlemm's canal. Please do not confuse this with neovascularization. Neovascularization has typical tufts of vessels. So this is blood in Schlemm's canal, which is due to regurgitation of the blood from the episcleral veins into the Schwalbe's, into the Schlemm's canal. Now coming to traumatic angle recession. Traumatic angle recession is after trauma, you will be able to see widening of the ciliary body band, as you can see here. This light brown line is the trabecular meshwork, and this is artificial widening of the ciliary body band due to split in between the longitudinal and the radial muscles of the ciliary body. and it also signifies that there has been significant trauma to the trabecular meshwork, which later on during the lifetime might lead to increase in intraocular pressure at any time. So if there is angle recession present in a case following trauma, the patient should be kept on a lifelong follow-up and counsel regarding increase in intraocular pressure that might happen anytime during the lifetime of the patient. Sometimes your ciliary body and the choroid itself might separate totally from your scleral spur and lead to a white band that is visible behind your trabecular meshwork. This is a cyclodialysis. As you can see that the iris and the ciliary body complex have separated from the root of the iris. Finally, the gonioscopy findings should be demonstrated in a goniogram in the patient's file, and you can make a two-circle diagram, the outer circle being the Schwalbe's line, the inner circle being the scleral spur, and you can denote in which clock hour what findings are present on gonioscopy. Also, multi-cross diagram to show that what is the angle structure that is present in your primary gaze, and when you do manipulation, you make an arrow and write what is the angle structure that is visible on manipulation and indentation. So this is a goniogram which you can make and denote the angle structures. Thank you so much. So we have a gonioscopy, a video assisted skill transfer approach, a video CD that is present, and that can be seen for the videos that are for gonioscopy. Thank you so much.
Thank you, Dr. Thavir. With this, we come to the end of the session. Thank you, all my fellow colleagues, for being present here. Thank my co-instructor, Dr. Sunita, Dr. Manavdeep, Dr. Pandav, and of course, Dr. Thavir. Thank you. Thank you very much.
Thank you.
वो भी कैटरेराइड उसको नहीं बहुत है, तो सारे कप डालने के लिए